A 55-year-old male patient presents with a blood pressure reading of 150/90 Fg during a routine checkup. He has a history of hyperlipidemia and is a current smoker. Discuss the management guidelines for this patient, including lifestyle modifications and pharmacotherapy. Answer: the patient in this scenario meets the criteria for stage 1 hypertension as per the 2017 American College of Cardiology American Heart Association (ACAHA) guidelines, which define stage 1 hypertension as a blood pressure of 130/139/8089 G. Management includes lifestyle modifications. The patient should be advised to quit smoking. Smoking cessation can significantly reduce cardiovascular risk. Adopt the DASH diet, which emphasizes fruits, vegetables, whole grains, and low-fat dairy. Exercise. Engage in regular physical activity, such as at least 150 minutes of moderate aerobic activity each week. Weight management. Achieve and maintain a healthy weight, BMI 25. Limit alcohol intake. Recommended limits are up to 1 drink per day for women and up to 2 drinks per day for men. Pharmacotherapy. Given the patient's overall cardiovascular risk profile, pharmacologic treatment may be warranted. Initial medications can include thiazide diuretics, e.g. hydrochlorothiazide ACE inhibitors, e.g. lisinopril if there is a compelling indication such as diabetes or heart failure. Calcium channel blockers, e.g. amlodipine, may also be considered. A regular follow-up should be scheduled to monitor blood pressure and adjust treatment as necessary. A 62-year-old woman with a diagnosis of type 2 diabetes mellitus is not achieving target glycemic control despite being on metformin. Discuss the next steps in her management, including potential medication adjustments and considerations for combination therapy. Answer: in this case, the patient is experiencing inadequate glycemic control with metformin monotherapy according to the American Diabetes Association (NADA) standards of medical care. The following steps should be considered. Assessment: reassess the patient's current treatment regimen, including adherence to medication, diet, and exercise. Evaluate for any barriers to control, e.g. lifestyle, psychosocial factors. Consider combination therapy. If the patient's hemoglobin HbAC is still above the target, typically 7% for most adults, adding a second agent is appropriate. Options for combination therapy include sulfonylureas, e.g. glipizide, increase insulin secretion from the pancreas, GLP-1 receptor agonists, e.g. liraglutide, improve glycemic control and promote weight loss. SLT inhibitors, e.g. empagliflozin, offer renal protection and cardiovascular benefits. DPP-4 inhibitors, e.g. sitagliptin, a less preferred option due to modest efficacy. Monitoring: regular follow-up visits should be scheduled to monitor glycemic control, e.g. HbAC levels, assess for side effects of new medications, and adjust the regimen as necessary. Mr. Thompson, a 68-year-old male with a history of ischemic heart disease and hypertension, presents to the emergency department with dyspnea on exertion, orthopnea, and peripheral edema. An echocardiogram reveals a left ventricular ejection fraction (LVEF) of 35%. What would be the most appropriate management strategies for Mr. Thompson considering his heart failure classification? Answer: Mr. Thompson presents with symptoms indicative of heart failure (HF) and has a reduced LVEF 40%, classifying him as having HREF heart failure with reduced ejection fraction. Acute management: diuretics. Initiate loop diuretics, e.g. furosemide, to manage fluid overload and relieve symptoms such as dyspnea and peripheral edema. Oxygen therapy: administer supplemental oxygen if he is hypoxemic. Vasodilators: consider intravenous nitrates if the patient exhibits hypertension or pulmonary congestion. Chronic management medications: once stabilized, initiate or optimize the following medications: ACE inhibitors, e.g. lisinopril, to improve survival and reduce hospitalizations. Beta blockers, e.g. carvedilol, to enhance cardiac function and reduce morbidity and mortality. Mineralocorticoid receptor antagonists, e.g. spironolactone, if the patient has symptomatic HREF, to provide additional benefits. Patient education: educate the patient on the importance of adhering to medication regimens, dietary sodium restriction, and regular follow-ups. Referral to a heart failure clinic may also be beneficial for comprehensive management. A 40-year-old woman presents with easy bruising and menorrhagia. Laboratory tests reveal a prolonged activated partial thromboplastin time (APT), but a normal prothrombin time (PT). What is the most likely diagnosis and what are the recommended management strategies? Answer: The patient's symptoms and laboratory findings are suggestive of a coagulation disorder like von Willebrand disease, which is characterized by a prolonged aptitude to a deficiency or dysfunction of von Willebrand factor diagnosis confirmation. Further evaluation including measurement of von Willebrand factor antigen and activity effector VII levels, which are typically low EW management strategies. Desmopressin, DDAP. This medication can stimulate the release of olia from endothelial cells, thereby increase olia levels and helping to control bleeding. Replacement therapy in severe cases or for major surgery olia concentrates may be necessary. Avoidance of certain medications. Advise the patient to avoid aspirin and other antiplatelet agents that may exacerbate bleeding. 30-year-old female patient with a history of asthma presents with worsening wheezing and shortness of breath. She is currently using a short-acting beta agonist SUBA as needed, but her symptoms have been occurring more frequently. Discuss the appropriate steps for her asthma management, including medication adjustments. Answer: the patient exhibits signs of poorly controlled asthma, indicated by the frequent use of a SABA. The Global Initiative for Asthma (GINA) guidelines suggest the following steps for management. Assessment of control. Confirm the frequency of symptoms. Nighttime awakenings and SABA use more than twice a week indicates poor control. Medication adjustment. Initiate or escalate to a low-dose inhaled corticosteroid e.g. fluticasone as a daily controller medication to reduce inflammation. Consider adding a long-acting beta agonist e.g. salmeterol to the regimen for better control if the patient's asthma is moderate to severe. Patient education. Discuss the importance of adherence to prescribed medications and proper inhaler technique. Review the action plan for worsening symptoms and the importance of having a written asthma action plan. Follow-up. Schedule a follow-up visit in 4-6 weeks to assess asthma control and adjust medications as necessary based on symptoms and side effects. A 25-year-old male presents with fever, fatigue, and a painful rash on his lower extremities. Laboratory tests show thrombocytopenia and elevated liver enzymes. Discuss the possible infectious etiologies in the initial management steps. Answer: the clinical presentation suggests a possible viral infection with differential diagnoses including dengue fever or viral hepatitis. Potential infectious etiologies: dengue fever, characterized by fever, rash, and thrombocytopenia commonly found in tropical and subtropical regions. Hepatitis AB can present with fever, rash, and elevated liver enzymes. Initial management steps. Supportive care. Provide symptomatic relief including analgesics. Avoid NSAIDs due to risk of bleeding. Fluid management. Ensure adequate hydration, particularly in cases of dengue, to prevent shock. Monitoring. Close observation of platelet counts and liver function tests to track disease progression. Further laboratory testing, including serologic testing for specific viral pathogens, is necessary for definitive diagnosis and management. A 70-year-old man with a long history of smoking presents with a chronic cough and increased sputum production. Spirometry confirms a diagnosis of COPD. Discuss the management approach for this patient, including pharmacotherapy and non-pharmacotherapy strategies. Answer: management of COPD involves a combination of pharmacologic and non-pharmacologic strategies. Pharmacotherapy, bronchodilators. Start with a short-acting beta agonist, SABA e.g. albuterol, for symptom relief, and consider a long-acting beta agonist, LABA e.g. salmeterol, for daily maintenance. Inhaled corticosteroids. Consider an ICS in patients with frequent exacerbations or significant symptoms, e.g. fluticasone. Phosphodiesterase 4 inhibitors. For patients with chronic bronchitis and a history of exacerbations, roflumilast may be beneficial. Non-pharmacotherapy, smoking cessation. Strongly encourage cessation as it is the most effective intervention to slow disease progression. Pulmonary rehabilitation. Refer the patient for a pulmonary rehabilitation program that includes exercise training and education. Vaccinations. Ensure the patient receives annual influenza vaccination and pneumococcal vaccination to prevent respiratory infections. A 65-year-old postmenopausal woman presents for a routine evaluation. A dual energy X-ray absorptiometry DEXA scan shows a T-score of negative 2.5 at the lumbar spine, indicating osteoporosis. Discuss the management options for this patient. Answer: management of osteoporosis in this patient should include both non-pharmacologic and pharmacologic strategies. Non-pharmacologic measures, calcium and vitamin D, ensure adequate intake of calcium 1200 mg day and vitamin D 800 1000 a day through diet or supplements. Exercise, recommend weight-bearing and resistance exercises to improve strength and balance, reducing the risk of falls and fractures. Lifestyle modifications, encourage smoking cessation and limiting alcohol consumption. Pharmacologic therapy, bisphosphonates. Start with a bisphosphonate e.g. alendronate or risdronate to reduce fracture risk. Other options, consider alternative treatments such as denosumab or teriparatide in patients with high fracture risk or those who cannot tolerate bisphosphonates. Follow up, monitor BMD and adjust treatment as necessary, typically every 1-2 years. A 58-year-old man with a history of hypertension and diabetes presents with fatigue and ankle edema. Laboratory tests reveal an estimated glomerular filtration rate (EGFR) of 45 mmHg and elevated serum creatinine. Discuss the management strategies for this patient's chronic kidney disease. Answer: management of CKD focuses on slowing progression and managing complications. Control risk factors. Blood pressure management. Target BP should be 138 mmHg, ideally using ACE inhibitors or ARBs to provide renal protection. Glycemic control. Tight control of blood glucose is crucial for diabetic patients to slow the progression of nephropathy. Dietary modifications. Protein restriction. A modest reduction in protein intake may be recommended, especially in advanced CKD. Sodium and potassium. Limit sodium intake to manage hypertension and edema. Monitor potassium levels to avoid hypokalemia. Monitoring and follow-up. Regular follow-up for kidney function, electrolytes, and potential complications. Anemia, bone disease. Referral to a nephrologist may be warranted as EGFR declines further or for advanced care planning. A 50-year-old woman presents with fatigue and pallor. A complete blood count (CBC) shows hemoglobin of 10 g/dL, microcytic red blood cells, and low ferritin levels. Discuss the likely cause of her anemia and the appropriate management steps. Answer: the patient's presentation is consistent with iron deficiency anemia, either characterized by microcytic red blood cells and low ferritin levels. Likely causes: dietary deficiency, inadequate iron intake, blood loss. Possible sources include menstrual bleeding, gastrointestinal bleeding, or recent surgeries. Management steps: iron supplementation. Initiate oral iron supplementation, e.g. ferrous sulfate, with guidance on dosing and potential side effects. Nausea, constipation. Dietary changes: advise on iron-rich foods, red meat, leafy greens, fortified cereals, and vitamin C intake to enhance absorption. Further evaluation: if the cause of iron deficiency is unclear or if there is significant blood loss, further investigation, e.g. stool guaiac test endoscopy, may be necessary. Follow-up: monitor hemoglobin levels and reticulocyte count after a few weeks of treatment to assess response. What are the key components of a medical history, and why is each component critical in forming a differential diagnosis? Answer: a comprehensive medical history comprises several key components. Chief complaint (CC). This is the primary reason the patient seeks medical attention. Understanding the chief complaint helps guide further questioning and focuses the examination. History of present illness (HEI). This section elaborates on the chief complaint. It includes details such as the onset, duration, characteristics, and any alleviating or aggravating factors. This information is crucial for understanding the context of the complaint and identifying potential underlying causes. Past medical history (PMH). This includes previous illnesses, surgeries, and hospitalizations. Knowing the patient's past medical conditions helps to identify potential complications and relevant treatment history. Family history (FH). Documenting family medical history is essential for identifying hereditary conditions and assessing risk factors for certain diseases. Social history (SH). This covers lifestyle factors, including occupation, substance use, and living conditions, which can influence health and disease risk. Review of systems (ROS). A systematic review of each body system aids in uncovering additional symptoms that may not have been disclosed in the initial complaint. Each component plays a vital role in formulating a differential diagnosis, ensuring a holistic understanding of the patient's health status. Explain the clinical problem-solving approach to recognizing clinical patterns in a patient presenting with chest pain. Answer: the clinical problem-solving approach involves the following steps. Recognizing clinical patterns. Clinicians must recognize common presentations associated with specific diseases. For example, chest pain can be categorized as cardiac, myocardial infarction, myangina; pulmonary embolism, pneumonia; gastrointestinal, esophageal spasm, gastroesophageal reflux disease (GERD), musculoskeletal, costochondritis, rib fracture. Establishing clinical context. Clinicians must consider the patient's history, risk factors, and associated symptoms, e.g., dyspnea, diaphoresis, to narrow the differential diagnosis. Formulating a differential diagnosis. After establishing a context, a differential diagnosis can be created. This may include common conditions like acute coronary syndrome and less frequent conditions like aortic dissection or esophageal rupture. Utilizing clinical algorithms, these can aid in streamlining the diagnostic process and ensuring key factors are not overlooked. Conducting focused testing. Based on the differential diagnosis, appropriate tests, e.g., CG, chest X-ray, D-dimer, can be ordered to confirm or rule out conditions. Discuss the importance of documenting findings during a physical examination and the potential consequences of inadequate documentation. Answer: documentation of findings during a physical examination is crucial for several reasons. Legal protection. Thorough documentation provides a record that can protect clinicians in cases of malpractice or disputes. Continuity of care. Accurate notes allow for seamless handoffs between healthcare providers, ensuring continuity in diagnosis and treatment plans. Quality of care. Well-documented findings contribute to higher quality of care by facilitating ongoing evaluations and monitoring patient progress. Billing and reimbursement. Proper documentation is necessary for justifying the services provided, impacting billing accuracy and reimbursement rates. Inadequate documentation can lead to misinterpretations of the patient's condition, compromised patient safety, and difficulties in defending clinical decisions if questioned. Mr. Thompson, a 58-year-old male with a history of hypertension and hyperlipidemia, presents with acute shortness of breath and chest discomfort. His initial ECG shows some segment elevations in leads I and F. What steps should the healthcare team take next based on the interpretation of these findings? Answer: given Mr. Thompson's presentation and ECG findings indicating some segment elevation, which suggests an inferior sunt elevation myocardial infarction (STEMI), the healthcare team should take the following steps. Immediate management. Initiate acute coronary syndrome ACS protocol, which includes administering aspirin and nitroglycerin provided there are no contraindications. Consideration for thrombolysis or PCI, depending on the hospital's capabilities and the timing of symptom onset, either thrombolytic therapy, if within 12 hours of onset, or percutaneous coronary intervention ECI should be considered. Monitoring. Continuous cardiac monitoring is necessary to track for potential arrhythmias or hemodynamic instability. Laboratory tests. Obtain cardiac biomarkers, troponin, CKMB, to assess myocardial injury, as they will help confirm the diagnosis of STE. MI. Consult cardiology. An urgent consult with a cardiologist is essential for further management, including potential catheterization. Patient education. Discuss the importance of lifestyle modifications and adherence to treatment post-acute management to prevent future cardiovascular events. When formulating a differential diagnosis for a patient presenting with fatigue and weight loss, what key factors should a physician consider, and how can these impact the diagnostic process? Answer: when evaluating a patient with fatigue and weight loss, a physician should consider the following key factors: duration and onset. Understanding how long the symptoms have been present and whether they were acute or insidious can help in narrowing down the potential causes. Associated symptoms. Gathering information on other symptoms, e.g., fever, night sweats, changes in bowel habits, can indicate underlying conditions such as infections, malignancies, or endocrine disorders. Past medical history. A thorough review of the patient's medical history can reveal chronic illnesses, e.g., diabetes, depression, cancer, that may contribute to the current symptoms, medications, and substance use. Current medications, recent changes in treatment, and substance use. Alcohol, recreational drugs can significantly influence energy levels and weight. Psychosocial factors, stresses including life changes and mental health status should be evaluated, as they may contribute to fatigue and weight loss. These factors impact the diagnostic process by directing the clinician to prioritize certain diagnoses, potentially leading to life-saving interventions or appropriate referrals. Compare and contrast the techniques of palpation and percussion in a physical examination, including their specific applications. Answer: palpation and percussion are both essential physical examination techniques used to assess different aspects of a patient's health. Palpation. This technique involves the use of the hands to feel the body's surface and underlying structures. Applications: assessing the size, shape, tenderness, and consistency of organs or masses. Identifying areas of tenderness or abnormal warmth. Evaluating the presence of fluid, G. In joints or abdominal cavities. Percussion. Percussion involves tapping on the body's surface to produce sounds that indicate the underlying structure. Applications. Determining the size and borders of organs. E. G. Liver, spleen. Assessing A. G. In the lungs versus fluid or solid masses. Differentiating between normal and abnormal findings. E. G. Dullness in cases of pleural effusion. What is the significance of obtaining a complete blood count (CBC) in the evaluation of a patient presenting with fever and malaise? Answer: a complete blood count (CBC) is critical in evaluating a patient with fever and malaise for several reasons. Detection of infection. An elevated white blood cell B can indicate an infectious process, while leukopenia may suggest a viral infection or bone marrow suppression. Anemia assessment. Low hemoglobin levels may be identified, suggesting anemia, which can contribute to fatigue and malaise. Thrombocytopenia. A low platelet count may indicate a bleeding disorder or underlying infection. E.g. sepsis, while thrombocytosis can be seen in inflammatory states. Differential count. Examining the differential count can provide insights into the type of infection, bacterial versus viral or inflammatory process. The results of a CBC guide further diagnostic workup, treatment decisions, and monitoring of disease progression. Describe how clinical algorithms can be beneficial in the diagnostic process and provide an example of one such algorithm used in internal medicine. Answer: clinical algorithms serve as systematic tools that guide healthcare professionals through complex decision-making processes, particularly in diagnosis and treatment. Their benefits include standardization of care. Algorithms promote uniformity in patient evaluation, ensuring that essential steps are not overlooked. Efficiency. They streamline the diagnostic process, enabling quicker decision-making by providing clear pathways based on clinical findings. Improved outcomes. By utilizing evidence-based practices, algorithms enhance patient outcomes and reduce the risk of errors. Example: the Acute Coronary Syndrome ACS algorithm guides clinicians in assessing patients with chest pain. It typically involves the following steps: initial assessment and triage based on risk factors and symptomatology, electrocardiogram and cardiac biomarker evaluation, risk stratification, low, intermediate, high, to determine management strategies including potential PCI or thrombolysis. Ms. Alvarez is a 45-year-old woman presenting with new-onset diabetes, elevated blood pressure, and unexplained weight gain over the last 6 months. What potential underlying conditions should be considered, and what initial diagnostic steps should be taken? Answer: Ms. Alvarez's presentation raises suspicion for Cushing's syndrome, particularly given the triad of new-onset diabetes, hypertension, and weight gain. Initial diagnostic steps: history and physical examination, comprehensive evaluation to identify additional features such as facial plethora, abdominal striae, or proximal muscle weakness. Laboratory tests: 24-hour urinary free cortisol. This test is a key screening tool for Cushing's syndrome, as elevated levels indicate excessive cortisol production. Low-dose dexamethasone suppression test. This test assesses the feedback inhibition of cortisol. Failure to suppress cortisol levels after administration of dexamethasone suggests Cushing's. Imaging studies. If biochemical tests are suggestive of Cushing's syndrome, imaging, e.g. CT or MRI, the adrenal glands or pituitary may be indicated to identify the source of excess cortisol. Discuss the concept of clinical patterns in the context of diagnosing pulmonary embolism, P, and the role of risk factors in this process. Answer: recognizing clinical patterns in patients with suspected pulmonary embolism, P, is essential for timely diagnosis and intervention. The key elements include classic symptoms. Common symptoms of PE include sudden onset of dyspnea, pleuritic chest pain, and hemoptysis. However, symptoms may vary based on the size and location of the embolism. Risk factor assessment. Evaluating risk factors is crucial. Factors such as recent surgery, immobilization, cancer, or a history of thromboembolic events increase the likelihood of PE. Clinical prediction rules. Tools like the Wells score help stratify patients based on their likelihood of having a PE, guiding the need for further testing. D-dimer or CT pulmonary angiography. Diagnostic testing. If PE is suspected, obtaining a D-dimer level can help rule out PE. In low-risk patients, if D-dimer is elevated, a CT pulmonary angiogram should be performed to confirm the diagnosis. By understanding clinical patterns and associated risk factors, healthcare providers can enhance the accuracy and efficiency of PE diagnosis, leading to prompt treatment and improved patient outcomes. What are the recommended screening guidelines for breast cancer in women, and how do these guidelines vary based on age and risk factors? Answer: Breast cancer screening guidelines recommend that women should undergo mammography as follows. Ages 4049. Women should have the opportunity to begin screening with a mammogram every year. The decision to start screening should be an individual one, considering the patient's health history and preferences. Ages 5074. Women should have a mammogram every 2 years. This recommendation is based on the balance of benefits and harms associated with screening in this age group. Ages 75 and older. The decision to continue screening should be based on the individual's health status and life expectancy. For women at higher risk e.g., those with BRCA mutations, screening may start earlier and additional imaging such as MRI may be recommended. It's essential to assess individual risk factors including family history, personal history of breast cancer and genetic predispositions. The U.S. Preventive Services Task Force (OSPS) and the American Cancer Society provide these guidelines, emphasizing that personalized care and shared decision-making are critical in determining screening approaches. Describe the role of healthcare providers in facilitating smoking cessation among patients. What evidence-based strategies should be employed? Answer: healthcare providers play a crucial role in facilitating smoking cessation through several evidence-based strategies. Screening and assessment. Routine screening for tobacco use should be integrated into clinical practice. Providers should assess the patient's willingness to quit and previous attempts. Counseling and behavioral interventions. The National Cancer Institute recommends combining individual, group, or telephone counseling with pharmacotherapy for effective cessation support. Motivational interviewing techniques can enhance patient engagement and readiness to quit. Pharmacotherapy. Evidence supports the use of nicotine replacement therapies (NRT) and prescription medications such as varenicline and bupropion to improve quit rates. Follow-up. Regular follow-up appointments should be scheduled to monitor progress and provide ongoing support. Providers can offer encouragement and adjust treatment plans based on the patient's response. Community resources. Referral to local cessation programs or resources, such as smokefree.gov, can provide additional support and accountability. Mr. Thompson, a 55-year-old male with a BMI of 32, visits you for a routine checkup. He has a family history of type 2 diabetes and cardiovascular disease. What risk factor modification strategies should you recommend, and what guidelines support these recommendations? Answer: given Mr. Thompson's profile, the following risk factor modification strategies should be recommended. Weight management. As Mr. Thompson has a BMI of 32, he falls into the category of obesity, which significantly increases his risk for type 2 diabetes and cardiovascular disease. The National Institutes of Health (NIH) recommends a weight loss of 5% of body weight as beneficial for improving health outcomes. Strategies may include dietary changes, reducing caloric intake, focusing on whole foods, behavior modifications, self-monitoring food intake, and possibly referral to a registered dietitian. Physical activity. The American Heart Association (AHA) recommends at least 150 minutes of moderate intensity aerobic exercise weekly. For Mr. Thompson, a gradual increase in physical activity, such as brisk walking or cycling, should be encouraged to improve cardiovascular fitness and support weight loss. Nutrition and diet. A heart-healthy diet, such as the Mediterranean diet, rich in fruits, vegetables, whole grains, lean proteins, and healthy fats, should be encouraged. The U.S. dietary guidelines provide a framework for balanced eating patterns that can aid in weight management. Screening for diabetes. Given his family history and risk factors, an assessment for prediabetes or diabetes should be performed, typically via fasting glucose or hemoglobin AC testing. This aligns with the American Diabetes Association (ADA) guidelines for screening high-risk populations. Monitoring and support. Establishing follow-up appointments to monitor weight loss progress and reassess risk factors can help keep Mr. Thompson motivated and accountable. What are the key components of lifestyle counseling that healthcare providers should address with patients to promote overall health? Answer: key components of lifestyle counseling include nutrition and diet. Providers should discuss the importance of a balanced diet, emphasizing whole foods, portion control, and the benefits of reducing saturated fats, sugars, and sodium. Counseling should be tailored to individual preferences and cultural backgrounds. Physical activity. Providers should encourage regular physical activity, recommending at least 150 minutes of moderate aerobic activity per week and muscle strengthening activities on 2 or more days per week. Discussions should include ways to incorporate movement into daily life. Mental health. Addressing stress management techniques, such as mindfulness, meditation, or cognitive behavioral strategies is vital. Providers should assess for signs of anxiety or depression and refer to mental health services if necessary. Substance use. providers should screen for alcohol use and illicit drug use, offering resources for cessation or reduction. The U.S. Preventive Services Task Force recommends screening for unhealthy alcohol use in all adults. Preventive Services discussion of age-appropriate screenings and immunizations is essential, reinforcing the importance of preventive care in reducing disease risk. How do screening recommendations for colorectal cancer vary between different age groups, and what factors should be considered when determining the appropriate screening strategy for an individual? Answer: screening recommendations for colorectal cancer (ERC) vary by age and risk factors. General population, ages 4-5-75. The USPSTF recommends that screening for CRC begin at age 45 for average-risk individuals. Options include colonoscopy every 10 years, flexible sigmoidoscopy every 5 years combined with stool testing, or stool tests like FIT annually. Ages 7-6-8-5. Screening decisions should be individualized based on health status, previous screening history, and patient preferences. High-risk individuals. For individuals with a family history of colorectal cancer, inflammatory bowel disease, or genetic syndromes, e.g. Lynch syndrome, screening may need to start earlier, often by age 40 or 10 years before the age of the youngest affected relative. Providers should also consider the patient's overall health and life expectancy when determining screening intervals. The importance of shared decision-making is emphasized in these guidelines, as patients should be informed about the benefits and risks of screening options, leading to a tailored approach that aligns with their values and preferences. What is the significance of alcohol use screening in primary care, and what standardized tools can be employed for effective assessment? Answer: alcohol use screening is essential in primary care because excessive alcohol consumption is associated with numerous health risks, including liver disease, cardiovascular problems, and mental health disorders. Early identification of alcohol misuse can lead to timely interventions that reduce the risk of developing alcohol-related conditions. Standardized tools that can be employed include AEDIT, Alcohol Use Disorders Identification Test, a widely used 10-item questionnaire designed to identify harmful and hazardous drinking patterns. Scores of 8 or more suggest the need for further evaluation. CAGE questionnaire, a brief 4-question tool focused on behavior related to alcohol consumption. A score of 2 or more indicates a potential alcohol problem and warrants further assessment. SASQ, Single Alcohol Screening Question, a simple question that asks, how many times in the past year have you had 5 for men or 4 for women or more drinks on one occasion? A positive response prompts further evaluation. Discuss the importance of counseling patients on physical activity and the specific guidelines that should be communicated to them. Answer: counseling patients on physical activity is vital for preventing chronic diseases, managing weight, improving mental health, and enhancing overall quality of life. The physical activity guidelines for Americans recommend that adults engage in aerobic activity, at least 150 minutes of moderate intensity or 75 minutes of vigorous intensity aerobic exercise each week, spread over multiple days. Muscle strengthening activities, engaging in activities targeting major muscle groups on 2 or more days per week. This could include weight training, resistance exercises, or bodyweight exercises. Flexibility and balance. For older adults or those at risk for falls, incorporating balance exercises and flexibility training can help prevent injuries. Counseling should focus on setting realistic goals, identifying barriers to physical activity, and exploring enjoyable forms of exercise. Healthcare providers should tailor recommendations based on the patient's current activity level, preferences, and any existing medical conditions. MS. Garcia, a 62-year-old woman, presents to your office for a wellness visit. She expresses concerns about her risk for osteoporosis as she has a family history of fractures. What screening and preventive measures should you recommend? Answer: for MS. Garcia, the following screening and preventive measures should be recommended. Bone density screening. The National Osteoporosis Foundation recommends that women aged 65 and older undergo a bone density test, DEXA scan, to assess bone health. Given her family history of fractures, earlier screening e.g. at age 60 may also be warranted based on clinical judgment. Calcium and vitamin D intake. Advise MS. Garcia on the importance of adequate calcium and vitamin D intake for bone health. The recommended dietary allowance for calcium is 1200 mg/day for women over 50, while vitamin D should be around 800-1000 e/day, depending on individual needs. Lifestyle modifications. Encourage weight-bearing exercises such as walking or resistance training, which can help strengthen bones. Medication consideration. Depending on the results of the bone density test and her overall risk factors, pharmacological interventions G. Bisphosphonates may be appropriate to prevent fractures. Fall prevention. Assess home safety to reduce the risk of falls, including environmental modifications and balance exercises. What are the current recommendations regarding cervical cancer screening, and how do these recommendations differ based on age and risk factors? Answer. Current cervical cancer screening recommendations, as outlined by the U.S. Preventive Services Task Force, include ages 21, 29, Pap smear, cervical cytology every 3 years is recommended. HPV testing is not recommended for this age group. Ages 3-6-5. Women have 3 options. Pap smear alone every 3 years. HPV testing alone every 5 years, preferred method. Co-testing Pap and HPV testing every 5 years. Over age 65. Screening may be discontinued if the patient has had adequate negative prior screenings. 3 consecutive negative Pap smears or 2 consecutive negative HPV tests in the past 10 years and no history of high-grade cervical lesions or cervical cancer. Women at high risk, those with a history of cervical cancer, high-grade lesions, or HIV infection may require more frequent screening or continued screening past the age of 65. What is the role of primary care providers in promoting lifestyle changes among patients with hypertension, and what specific guidelines should they follow? Answer. Primary care providers play a crucial role in promoting lifestyle changes among patients with hypertension through the following strategies: assessment and education. Providers should routinely assess blood pressure and educate patients about hypertension, its risks, and the importance of lifestyle modifications in managing their condition. Dietary recommendations. The DASH dietary approaches to stop hypertension diet is recommended, emphasizing fruits, vegetables, whole grains, lean proteins, and low-fat dairy while reducing saturated fat and sodium intake. Providers should work with patients to create personalized meal plans. Physical activity. Providers should encourage regular physical activity, aiming for at least 150 minutes of moderate intensity aerobic exercise weekly. Discussing achievable goals and incorporating exercise into daily routines can help patients adopt these changes. Weight management. Providers should discuss the importance of maintaining a healthy weight. A weight loss of 5-10% can significantly lower blood pressure. Encouragement and support in achieving this goal are essential. Medication adherence. For patients already on antihypertensive medication, discussing the importance of adherence to prescribed regimens is vital. Regular follow-ups can help monitor blood pressure and adjust treatment as needed. Behavioral support. Behavioral interventions such as motivational interviewing and goal-setting techniques can aid in the sustainable adoption of lifestyle changes. Following guidelines from the American Heart Association, AHA, and the Centers for Disease Control and Prevention (CDC) will support comprehensive care in managing hypertension.